our third anniversary meeting of the Right Care Initiative. Most of you know me. I'm Hattie Hamley. I co-lead the Right Care Initiative. This is a project that we call the we thing, because it's every single one of us in this room working together collaboratively that are healing hearts and saving lives. Healing hearts and saving lives. Healing hearts and saving lives. I said that 3 times because we've been meeting together for 3 years in this room, and that's what we're doing together, and only together can we achieve this goal of healing hearts and saving lives in Sacramento and the capital region. The work that we do here has resonates not only across our community, which has a higher incidence of heart attack and stroke, and thank you, Heart Association, Mick Smith, for being with us again. Our quiet, silent partner in the back. Mick is always with us, but very quiet. We have wonderful partnerships that make the Right Care Initiative work, and we have wonderful speakers who come together. Not only do we bring the best performers in California to teach how they did it and to mentor others, they always become sort of available faculty, but we have people from around the country that are working with us in the Right Care Initiative. So Gunderson Healthcare, as you recall, was with us in March of this year. Gunderson has the 4th best blood pressure control in the country, and their chief medical officer has become a wonderful advisor to the Right Care Initiative, Dr. Mike Dolan. And he brought with him pocket cards that Dr. Rebelo will be talking about in a minute, that they use. It's a practical, old-fashioned tool. They give it to all of their providers, and they use the multifaceted approach to improving blood pressure control. So to remind all of you in this room who have been with us month after month, year after year, we're working to reduce heart attack, strokes, and diabetic complications, and we're doing it through a wonderful multifactorial partnership, and we're celebrating this 3rd year anniversary by doing what is to some verboten, which is have a celebratory cookie. So Sierra Health used to provide us with cookies, but one of the doctors, probably in this room, I don't remember who it was, complained vociferously.
It was Dr. Kaufman.
I didn't hear that, and then don't say who it was, but we got cut off from cookies because we're working on reducing heart attack, strokes, and diabetic complications. So, but I thought for this 3rd year anniversary we could do 2 special things. One is I bought the cookies from our wonderful local vegan bakery up in Auburn, and we also have a project coming to fruition around creating our own pocket cards for improving hypertension in the Sacramento region. So with that, I'm going to hand it over actually to Dr. Rebelo to say, to get things going with introductions around the room.
So again, thank you for being here on our 3rd anniversary, and we didn't think that we'd stay together this long, although we hope we would. We thought that there would be enough interest in the work that we're doing, as Hattie had said, to really reach out and improve cardiovascular complications in the Sacramento region. So sharing best practices and working together has really key about right care. So thank you for being here. And one of the things that we wanted to first start out is introducing people around the room, self-introduction. So can we get started?
Got the microphone here.
Okay, let's start with Jerry.
Let me get it on here. Jerry Chapel, California Chronic Care Coalition.
Gil Simon, I'm the founder and medical director of Sac County Medical Clinics.
My name is Kathy Calrati Thomas, and I do Nevada County FC Support Group and Task Force, Nevada, California Task Force.
Hi, I'm Sue Quintus with the University of San Francisco Sacramento campus. Thank you.
I'm Bill Remack, I do the camera.
Chronic Care Coalition.
Chronic Care Coalition.
Thank you for wonderful volunteers in the Chronic Care Coalition.
Olivia, Senior Public Health Officer for Sacramento.
Stefan Schwartzwelder with the Palo Alto Medical Foundation.
Hello everyone, Dina Jacinto, I'm with AbbVie, the Population Health Division.
And Terry Hill, Vice President of Hill Physicians.
Jim Corcus, Medical Director, United Healthcare.
Marcia Richardson, Sac State intern, my major is sociology.
Doug Robertson, Regional Director for Health Physicians.
Cindy Hawkart, Vice President of Accountable Care with Sutherland Health Solutions.
Hi, Devashish Dave Mitra, Director of Physician Officers with Health Services Advisory Group.
David Matsumura, Nova Nordis.
Sophie Carr, California North State University, supporting the Sutter Health Family Medicine residency as a pharmacist.
Sean Aitha, the Vice President of Business and Network Development for River City Medical Group.
I'm Nick Smith, I'm the American Heart and American Stroke Association, Regional Director of our Quality Systems Improvement Program in Northern California.
Hi, I'm Jacqueline Weiss, I'm a Regional General Manager for Genentech.
Heather Chandler, Sutter Medical Foundation.
And Western Medical Foundation.
Hi, Neil Kawatsu, Department of Healthcare Services.
Neil, we got the table, get there.
So Dr. Neil Kohatsu with the Department of Healthcare Services as the Medical Director for the Medi-Cal program. So if you all don't know him, he's been wind under the wings of the Right Care Initiative since about 1998.
Hi, Jennifer Byrne, Department of Healthcare Services.
Dan W. with Barrington Eagle Line Pharmaceuticals.
Mike Strong with Nova Nordis.
Jan Vandermeer, Ambulatory Care Management Director for the Valley area for Sutter. Hi, Juliana Burton from UC Davis.
Hi, I'm Blair Barrett with Quality Improvement at Blue Shield.
Martha Garrity with Healthcare, representing cardiovascular health education programs for Northern California.
Deanne Blankenship with California Health Collaborative.
Joan Morgan, Vice Chair of the California Health Collaborative.
Hi, Sarah Brassby, Northern California Healthcare System.
Hi, I'm Karen Sykes with Johnson & Johnson Healthcare Systems.
Hi, Lisa Goldberg. I'm the CEO of the California Medical Association Foundation, which includes the network of ethnic physician organizations.
Rachel Simon, I'm the Chief Strategy Officer for Elephant Health Centers.
I'm Janet Fox, I'm with Pfizer, I'm Medical Director for Diseases.
Did we get everybody?
No, we have.
Juanita Riveros with California Rural Legal Assistance Foundation.
Thank you. And again, we wanted to just thank, although she's not here, but thank Sierra Health Foundation for continuing to support our work and provide the food that you're having this afternoon. So,
Jose, we want to begin. Warren Barnes.
I'll just introduce them to just in the interest of time. We have Martha Garrity with HealthNet. We have Warren Barnes with Grace Presbyterian and UC Berkeley School of Public Health. Harissa Vatenka and Stan Long with Safeway. I know that others will be coming in late. Dr. Susan Ivey, professor at UC Berkeley School of Public Health also. And we have a very special federal guest today, Dr. Betsy Thompson, who's been a supporter of Right Care since our very early days. I will just hand it back to you to.
Good, thank you. And well, let's get started because we have a lot of work to do today. And first of all, wanted to identify that we have now an algorithm that has been a card that's been developed through the work with Right Care. This is our first product, and many of you have been approached and have been asked if you would like to have copies. We have a limited number that actually Hattie has been able to put together, and I think that's being distributed today, right, to those individuals who have.
Yes, so everyone should have received one with their materials today, and then for those medical groups that I've been able to get in touch with that would like copies of the hypertension algorithm, it's the JNC algorithm that Dr. Susan Ivey, Dr. Arevalo, Dr. Ferguson have led up with Amanda Liu's assistance on the graphics, just to make it in a practical form for the providers to use. So if you're a provider group and you haven't already told me the number of the cards you want, please do that. And I want to say that through Dr. Neil Kohatsu's partnership with the Medi-Cal program, they're going to be producing an extra 1,000 of them for use with providers who also serve Medi-Cal. So just make sure you let us know how many you need for your physicians. And the keeper of these cards, and these are valuable cards, I just have to say, they cost us over $1 each to create. Right Care funds are very limited. It's at all charitable contributions that support the Right Care Initiative. And thank you to Novo Nordisk, AbbVie, Genentech, Boehringer Ingelheim, and J&J, the California Healthcare Foundation, and the California Endowment for helping us keep the Right Care Initiative alive. This is absolutely a collaborative operation, and Medi-Cal is a huge collaborator for us. So, yes?
This is Sean. Just a quick question. Is this the same card that was distributed by the organization at their conference?
It's very similar. So they were going to produce this. They did something kind of similar based on, they're part of our Los Angeles group, and they offered to produce some for their CAPG conference.
I picked up a giant stack just so I wanted to make sure that if it's different.
If you have a giant stack and you don't need them.
Well, no, I want to make sure we're giving the right thing. That's the point.
Yes, so it's JNC8, which is Dr. Revlo, Dr. Ivey, and Dr. Ferguson went through all the various hypertension algorithms in the universe that have been creating a lot of confusion, and decided to use the most current national guidelines. That's all these are. It's the Joint National Committee for Hypertension. Every few years they put out a new guideline, and Dr. Revlo has spent countless hours on the weekends with Dr. Susan Ivey, Dr. Ferguson, working through every single space and character with Amanda Liu. Please raise your hand. She has a pre-med from UC Berkeley who made this beautiful thing come to reality. And thank you for your patience working through all the many changes. So please pay careful attention to these footnotes. Medi-Cal helped us with this as well, making sure every bit of wording is just exactly what the physician community would want it to be.
To answer Sam's question.
Do you want to go to the microphone?
Yeah. To answer your
question. This is not exactly completely the same as what CAPG produced. CAPG produced the algorithm based exactly on JNCA guidelines. This algorithm, the only difference between this and CAPG one is for the age group of 60 and above, we made an asterisk there to say that there's controversies regarding the hypertension, the blood pressure threshold. Okay. The JNCA says 150/90, but there are a lot of medical groups and cardiology groups that disagree with that. So we just made an asterisk to remind people that there is some controversy.
So I'm going to read the exact wording that we worked out with Medi-Cal, because the issue is, at what age do you relax the hypertension benchmark? And JNC8 says 60, the international hypertension guidelines say age 80, and let's see, we're going to test my old eyes here. It says, while the 8th Joint National Committee currently uses a goal of less than 150/90 for adults age 60 and older, this recommendation is undergoing discussion and refinement by multiple national organizations, AHA, ACC, CDC, etc., based on evolving evidence. So what we decided to do is, recognizing that the evidence is always evolving, stick with, and thank you, Neil, for that footnote, because Dr. Neil Kohatsu is the one who said, just address that controversy. And so many of you have had input into the footnotes here, which are important. So does that answer everybody's question? Did you have something you wanted to add, Neil?
No, I think the collaborative process and just acknowledging it, because when you go out to groups and they say, yes, but you don't even, this is controversial, to put it out on the table, I think allows us to go to a broader audience and say, we understand that individual practice variation can be addressed. And that's how we learned from Kaiser. People think Kaiser just hands it out, and that's not how it works. You work through your local culture, right?
Great, thank you. And Lisa Folberg with the California Medical Association Foundation, we'd love your partnership on getting these out to the physicians who need them.
And again, the point of this is that these are guidelines. I mean, these are not standards of care. We keep saying that. So, and as I think Patty mentioned, maybe next month that new data will come out, and all of a sudden this would be necessary change. So, but it really is a kind of a guidepost, a roadmap for clinicians. And the beauty of this is that it fits in the pocket. It's not, sitting somewhere in a desk or, in a file on your computer where it's not useful. You can pull this out and it's helpful. And I think that's really what we wanted, is for doctors to have something, and other clinicians who make clinical decisions on hypertension, that they can really refer to as, something that's been vetted by a large group like the JNCA. And even with those controversies, almost in every single realm of medicine about treating patients, you will find some controversy. So that should not prevent us from the good being the enemy or the perfect being the enemy of the good. So this is the good, this is not the perfect. So, but again, it really will be, it's going to be helpful, especially for those clinicians who are not within healthcare systems that provide them guidance and help them with doing this much more easily within their EHR and things like that. So I think that's where we're not saying to Sacramento, this is what you need to follow. That's not what we're saying at all. We're saying here's something handy-dandy that's been vetted, that is based on evidence that you can, as a clinician, be able to turn to and use for your patients. So that's the whole point of this. So I think this is a really great product, and I'm really proud of Right Care for putting it together. So now, and by the way, so hopefully soon, if you do want some for your clinicians, let us know, and then as soon as we can get the resources to print it out, we'll make this available. And if you have perhaps some resources that can help us print it out some more if we get to the point where we're going to need more, and I think we will. We'd love to have your input on that. So thank you. But now,
And thank you, Dr. Revelo, for bringing this idea to the table. So starting in about December of last year, Dr. Revelo said, let's do an algorithm on hypertension based on the available evidence. Let's use an existing algorithm and distribute that to make sure that we address this higher incidence of heart attack and stroke in the Sacramento area. And then we had that wonderful speaker from Gunderson Healthcare in Wisconsin that said part of the way they became the 4th highest performer in blood pressure in the country is by using handy-dandy pocket cards. So the proof is in the pudding, as they say. And Dr. Revelo did this initially in diabetes in Sacramento many years ago. So hooray, Dr. Revelo and team for getting that.
Joan Werblin is here with the diabetes guidelines. So thank you, Joan. Good word. So I want to move, because we've got these great presentations today. We've got 2 excellent presentations that we want to move toward. And first, I don't think she needs an introduction, but I really do think, with respect to her, I should do at least a brief introduction for Dr. Betsy Thompson, who is the Deputy Regional Health Administrator for Region 9 here, and in the Office of the Assistant Secretary for Health, and who basically has done a huge, wonderful job and has been part of Right Care for quite a while. You've been with us for many of our meetings and helping us with providing input. And you know, Dr. Thompson has done a tremendous job in the region. How long have you been in the?
Well, six years.
6 years, yeah. And in a variety of ways, we've met and done work outside of Right Care, and we want to thank you for your input. And now with I think the main administrator has left for Region 9, and you're now being the interim administrator as well.
Oh, yeah.
For the time being, so you got a big job. But so today, Dr. Thompson is going to share with us a model, which is a million hearts cardiovascular disease risk reduction model, which is actually a payment model, not an app. And it's a project that she's going to share with us that they're spreading out 2 practices in the community, and we're going to hear a lot more about how this will move the Million Hearts program even further. And again, we are part of the Million Hearts campaign. That's what got us started. So we're happy to hear from Betsy.
Thanks. It's a real pleasure to be with you here again today. A little disclaimer, I really hope that Ashby Wolf, the current Chief Medical Officer for CMS, could have done this presentation because she's talking with a lot more practices than I am at this point. But I thought it was important to get it in front of you because the time is right. The call for practices to participate in this particular project is now. For those of you who have been watching or been involved in Million Hearts, as many of you have since its inception, this is sort of new because it's really the first time there's kind of money on the street for fee-for-service physicians to actually do something around Million Hearts. So I personally was very happy to see this announced. I don't need to give you the information on the background or the rationale. I mean, you all are here because you know how important heart disease is to our patient population or to our nation, actually. So what I think does bear saying, though, is that we have for a long time focused, especially we in the feds and what we can measure, have focused on these specific process measures, the things that we can easily get at, like LDL cholesterol level or blood pressure. And looking at those risk factors sort of as independent conditions rather than sort of the whole patient and what's going on with them. And with patients themselves often having very little idea about their own risk and for either heart attack or stroke. So this model was designed to use data and an algorithm that's widely accepted to provide those patients with their actual 10-year risk score, and for providers to actually get value-based payment for doing so, and for not just giving them the risk score, but actually looking at and managing, helping to reduce the risk across their entire panel, looking at a population and not just the individual patient, as those of us who practice in fee-for-service know we've been incented to do. So this continues our three-part aim of better care, smarter spending, and healthier people to get to where we need to be. I kind of alluded to this already, that this is the first CMS model that's incentivized reduction sort of in a predictive fashion, and hopefully we'll see more innovations like this in the future, not just from the Innovation Center where this model is coming from, but from CMS, so that we can focus more on meaningful and patient-centered outcomes. The other thing that's a little bit different about this than many things that CMS has rolled out is there really is a pretty rigorous evaluation design that is part and parcel of it from the get-go, and we very much need these kind of data if we want to see these types of efforts accelerated. The risk estimator that's going to be used is the ACC-AHA pooled cohort risk estimator, which I think most of you are fairly aware of. The idea here is that the providers will get incentives for the risk stratification initially, for sharing decision-making with the patients so that they both are in some ways accountable for that risk reduction that we're actually looking for, and it will be, as I mentioned, over the provider's entire panel. Practice eligibility requirements are listed on this slide. Note that they do have to meet the criteria for the Medicare EHR incentive program for 2015 performance year, which means, of course, that they have to use an ONC certified electronic health record. I think all of you are already doing that. The design is a 5-year test with a randomization of practices either into control or intervention practices. We expect to have about 300,000 Medicare beneficiaries total in both arms. I said there'll be an initial risk stratification, and that will actually be performed on all the Medicare beneficiaries between the ages of 18 to 79. In the intervention practices, there are some exclusion criteria that are listed on this slide as well. The treatment of high-risk beneficiaries will be followed through claims-based outcomes on all of those patients, on all patients, but then for the high-risk beneficiaries, that is where their risk score is 30% or greater, the provider will also do enhanced or more regular reporting on their longitudinal risk. So there'll be one-to-one randomization of practices. They looked at things like power to detect both the primary outcomes, which will be reduction in heart attack and stroke, as well as absolute risk reduction. And then the secondary outcomes will be the total cost of care, as well as improvement in our physician quality reporting system measures. The payment model is that there'll be a $10 per beneficiary one-time payment for the risk assessment itself. And for the high-risk beneficiaries, there's actually an additional $10 beneficiary per month to help with that care management fee, and will depend on the high-risk panel-wide risk reduction, how much they actually receive. So year 1, they're paid for reporting only, and year 2 through 5 will be that performance-based incentive. So again, this is really pretty new stuff for CMS to be venturing into on a population level. The model simulations show that the average practice has the potential to earn about $34,000 more with the assumptions listed on the right here of practices that have 4.4 providers per practice and about 400 beneficiaries, with 50 of those being high risk. So, not perhaps a huge amount of money, but it's also, I would argue, that's a little more than chump change for most practices these days. And it's something that should help drive the practice forward. There will be a data registry that's provided to the participating practices for free and a web-based tool allowing them to calculate the risk, share some decision-making tools, et cetera. They will be reporting both clinical variables and then the physician quality reporting system variables I mentioned. And this is actually the slide, the timeline slide for it. So applications are going on now. I expect to be reviewed and selected this fall, with it going live January of 2016. One thing I didn't mention is the control practices also do get, they have much less work that they have to do. It's basically reporting, I think 4 times through the 5-year period. So they will be paid $20 per beneficiary per reporting period. So there is payment involved, whether your groups are randomized to the control or the intervention group. I will stop there, and if you have questions, I will try to answer them, but if I can't, I'll bring them back and we'll get an answer to you. I hope that this is relevant. Some of you I know are completely in the managed care space, maybe not so relevant to you, but tell your friends and associates about it if you have folks who are serving fee-for-service beneficiaries. Thanks.
So
I have a question. Can the algorithm actually be supplied so you don't have to use a web-based tool? Because if I had the algorithm and extract the data from claims and from the EMR, I might be able to do the whole thing all at once on my entire population. Because one at a time is for me.
So doing the risk assessment.
That's correct.
You know, I'll take that question back because I understand what you're saying and I think that makes a lot of sense, and I'm not sure it does have to be done one at a time. Mary, do you have any knowledge of that?
Well, again, you enter the data on the patient page, blah, blah, blah.
Right, and
It's
if
one
you
at a
already
time.
have it.
If you already have it in the EMR and you codify data, then I can just do that on 50,000 people at once rather than one at a time.
Right, and my guess, but I'm not certain, is if you can do that, then the question is how do you dump that to CMS? How do you get it to them? And so that's really the question. Is there any interface built to do that? And I don't know the answer to it because you having it doesn't translate to CMS having it. So, but when you're using a certified EMR, I'm not sure there isn't a way. I just simply don't know the answer, but we will look for that.
So there actually already is an app that does this, that is from, is it on? AHAACC, so it's exactly like the web-based one that you're showing. But again, if for our practitioners, if they're using the app, you would want that to be able to link somehow without them having to also go back to the computer like Alan's saying.
Right.
And you're required to do annual reporting, right? And doing it one at a time again.
Yeah, and I'm not saying you have to, I'm just not sure. I'm a little, given that they're paying for reporting, I think that it may be that, but I think it's an excellent point, and I certainly will raise that and see if we can get you all an answer.
In this kind of model, how do you address outreach and community involvement?
Well, this model is really a practice-based model, right? So it's for practices to determine how they're going to do that. I don't know how many of you saw the community guide, I think just today.